Good afternoon, everyone. I'm Lisa Moorhead with the Joint Commission, and on behalf of myself, Ashley Kruger, and Mary Way, we are happy to be able to talk with you this afternoon about the Joint Commission's virtual accreditation and certification processes. I am currently the Associate Nurse Executive at the Joint Commission. I've been with the company now for about 10 years, first as a surveyor in the hospital program, and then as Director of Field Operations for the hospital, Critical Access Hospital, and Nursing Care Center accreditation programs. A little bit about my background. I've been a nurse for 38 years now. I have worked as a clinical nurse specialist. My master's is as a family nurse practitioner. I've had numerous responsibilities, operations, education, advanced practice throughout that time. And prior to joining the Joint Commission, I worked with hospitals and hospital systems to help them better understand Joint Commission requirements, CMS, and state requirements. So enough about me. Ashley, would you like to introduce yourself?
Good afternoon, everyone. My name is Ashley Kruger. I'm the Associate Director of Program Management here at the Joint Commission. I have been with the Joint Commission for 10 years and work on a lot of the strategic projects within the enterprise and work with Lisa and my other counterparts on those initiatives. So I will hand it to you, Lisa, to get us started.
Okay, Ashley, thank you. And then our colleague, Mary Way, is also on the call and is assisting Ashley and I. And Mary will be available at the end of our program to help with any questions. And then she will be your contact for any further questions, excuse me, after this presentation. So we have some objectives for this afternoon's discussion. The first one is to talk about the Joint Commission's virtual survey and review model. We have that keyword of current because, our process continues to evolve as we get better at it and as criteria for on-site surveys and virtual surveys are modified and changed. We'll talk a little bit about some of the key differences between an on-site event when compared to a virtual event. And then we'll also talk about some of the lessons learned that we have gleaned from our virtual surveys and reviews. Mary, next slide, please. We'd like to begin our discussions at the Joint Commission just to do a bit of a level set with our vision and mission. And so our vision is that all people always experience the safest, the highest quality, the best value healthcare across all settings. And then our mission, how we put that vision in place, is to continuously improve healthcare to the public as we collaborate with our stakeholders. And part of this collaboration is that evaluation of healthcare organization and inspiring them to excel and improve as part of our work with organizations in our surveys and reviews. And so we felt at the beginning of this pandemic that we needed to explore additional possibilities of how we could put our mission into place during this pandemic, which led us to developing a virtual process so that we could, if we were not able to physically visit an organization, that we could use technology in order to do that. Next slide, please, Mary. And so the first few slides that we have for you this afternoon gives a little bit of a background as far as what led us to our virtual survey process and then how that has evolved as we've gotten further along in our pandemic response. So in summary, beginning March 16th through May 31st, we suspended all of our on-site survey and review activity directly related to the pandemic. And during this time, we focused our efforts primarily on advocacy, but also developing resources and working to improve our internal processes. We had the benefit of 600 experts, our surveyors and reviewers, being available to help us look inwardly to how we could make modifications to our process, develop new processes, and then, of course, improving our work. For advocacy, oh, Mary, would you mind just to go back? For advocacy, I wanted to mention a couple of key components here. One is the work that we did in advocating for our organizations in establishing waivers to conditions of participation. So a lot of work was done there in the establishment of those waivers and the communication as a result of those waivers. And then the work that we did in order to get approval for a virtual survey and review process. There was a lot of approval and negotiation that had to happen, both for our deemed programs from a CMS perspective, but also Mary had done a lot of work with our states for approval of our virtual survey processes. So a lot of advocacy work happened during this suspension of surveys and reviews. I also wanted to mention the resources that we have at our Joint Commission website, and this is available to anyone at our jointcommission.org. There's /COVID. We spent the first couple of months looking at resources that were available, as well as developing our own resources that we've made available to the public. So just wanted to call attention to a couple of those bullet points on this slide. Mary, would you mind to advance the slide now, please? Thank you. A little bit more on those resources. We have conducted a number of webinars for our different accreditation programs. And these webinars are available for replay, as well as the slides or the PowerPoint presentations that are available there. A lot of our webinars focused on reopening, also focused on infection prevention and control with our infection preventionists in collaboration with the latest information from CDC and others. So the webinars have been very helpful to our organizations, but these are available to anyone in the general public. So webinars have been very helpful. We have created a number of infographics. One in particular highlighted here is related to aerosol generating procedures. We have some others there around staff as second victims. There's numerous blogs, position statements, and all of that is available at our Joint Commission site. So just wanted to mention that. And next slide, please, Mary. We also have made available data that we use in order to make decisions on when we would conduct an on-site survey or review compared to when we would conduct a virtual event. And we have made this data available to the public at our Joint Commission website. And the breadcrumbs that you see there in the middle is how you can find I'll call it a dashboard. You'll see it here in a minute. But it's through our operations research department. And then once you get to that page, if you scroll down, you'll see the button there, View Community COVID Rates. And that information and that data is available to anyone. So, excuse me. So you would see the information that we use to make those determinations of on-site versus a virtual event. Next slide, please, Mary. This is an example of that data I was mentioning. And so what we evaluate primarily is that first graph. So you'll see that red, that red graph. What we are looking at here is prevalence. So the number of cases per 1,000 population, and it's for a 2-week period. And so in this case here, I pulled this information middle of November, and the prevalence across the country was 5.69 per 1,000. When I checked yesterday, that number had increased in just, let's say, 3 weeks, from 5.69 per 1,000 to 9.21. Now, this is for the entire country. If you notice the yellow boxes, you can manipulate this information according to your state. So if you wanted to look at Illinois, that drop-down box would allow you to do that. My home state of Alabama, I can see my home state there. You can also find your particular county within your state so that you can see to a county level what the prevalence is and some of the other indicators that you can see here. We look at this to make determinations on lower risk counties and where we feel like it's safe for you, organizations within your state, as well as our surveyors to go on site. If an organization is in a county that does not meet our lower risk criteria, then there would be a virtual option if it is available. So I'll get more into that criteria here in a minute, but wanted to share the metrics that we use to make determinations on on-site versus virtual potential events. The blue line graph that you see is the ratio of what is that prevalence or the new cases increasing or decreasing. So of course we look at a ratio, the immediate past 2 weeks compared to the 2 weeks before, and we want to see that number to be 1 or below. In this case, with 1.5, the cases are increasing across the country. Excuse me. We also look at current percentage of positive rate. Across the country, you can see 17.91. We want that to be as far away from 20% as possible. To us, that gives us the indication that there is sufficient testing in the area to have a lower percentage of positive cases. So we consider these factors in making determinations of low-risk counties compared to counties that might be at a higher risk where we would not send a survey or review team. Next slide, please, Mary. During the public health emergency, there are 2 options, and I've alluded to those. There are 2 options for survey and review activity: the lower risk counties, where we would consider sending a survey or review team, and then those that would qualify for virtual events, being in lower risk, in those lower risk. If the criteria for lower risk counties are not met, then we would consider a virtual event. Now, there's some caveats here in that the states would have to allow a virtual event. Some of our states, particularly just as an example, within the behavioral health program, there are some limitations per states of what we can do virtually. There are also some limits on if it's a deemed organization or a deemed survey event. There are some restrictions there to what we have been approved to do virtually. And so all of this goes into our decision making on scheduling a virtual event compared to an on-site event. Most of our organizations will receive an outreach call prior to scheduling either option for a survey or review activity, and I'll share a little bit more about that outreach call. But we wanted to share with you the number of surveys and reviews that we have been able to conduct as of June, or starting June 2020, up until mid-November. So you can see just under 3,000 events, and the comparison between on-site and virtual events. I wanted to share with you here, though, that as of Monday, we have scheduled over 1,000, almost 1,200 events virtually, compared to the 925 that you see on the slide. So we are continually expanding our virtual survey and review options, and continue to evaluate those and schedule them. As far as the evaluation, when we make those outreach calls, we are wanting to determine if our organizations can support either an on-site or a virtual event. Mary, would you mind to advance the slide, please? I had mentioned the criteria of lower risk counties, and we're looking at cases per 1,000 events. And the rate that we're looking for, um, it changes as there's new evidence and new data, and as we gain a better understanding of the reaction or the patterns of this virus and the pandemic. For example, when we first started back in June, we were looking at cases per 1,000 residents at about 1.4. That's considered lower risk counties. As more information and data and research has become available, we have modified that and increased it to 2 per 1,000. And now we are looking at anywhere from 3 to 3.5 per 1,000 residents as meeting our operational definition as a lower risk county. There are some other factors that we consider, though. State level restrictions, I mentioned in the context of the state approval, but there are also state level travel restrictions that come into play that we need to consider. Although we have been approved as essential workers, there are still some restrictions from our surveyors and reviewers for travel, um, particularly travel back to their home states, that we need to consider. I mentioned testing capacity. We want to make sure that there is enough testing within a particular county that we can have confidence in the data around prevalence and ratio of increases, decreases in the trend over time. We want to make sure that there's enough testing capacity to have confidence in those numbers. So the further away from 20% of positive rate that we can get, the more confident we are in those numbers. And then I mentioned the trending growth rate. We want to see that at 1 or below so that there's not a steady increase over time in the prevalence within a particular area. Next slide, please, Mary. This is a depiction of the counties that are available for us to go on site for survey and review during this public health emergency. And this slide is a depiction of the decreases in the available counties that we have to go on site. So this particular graph will show, if you look at the blue line is those counties, or it depicts those counties where we would actually send a survey team. The green line is our initial toll gate. The first hurdle is cleared, and we start to watch the counties for scheduling. So in the previous slide, the other variables that I mentioned, where we're looking at the positive cases within an area, we're looking at changes in travel restrictions. We're also looking at overall prevalence. And so by the time we're ready to send in a survey team, those potential counties went from 827 to 362 in this slide. So as a reference, there's about 3,200 counties in the US. As of this morning, I had received word that currently we have 175 counties after that, out of that 3,200 counties, where we feel it will be safe to send a survey team. So in discussing this with you, what we had hoped to establish for you is the parameters that we use to evaluate lower risk counties and to give you an idea of the opportunity that we have for those virtual events. Next slide, please. I had mentioned the outreach calls that we conduct as part of the public health emergency, or during the public health emergency. Primarily, these calls are determined if our organizations can support any survey or review activity, whether it is a virtual event or an on-site event. So we want to make sure that our organizations no longer have their emergency operations plan active. Now, by active, we can have an organization that tells us we have our emergency operations plan open, so that we can make use of the waivers that are available to us. But we don't have daily, multiple time a day meeting. It's no longer active. It's in place, but we don't consider it active. We want to know about the waivers that an organization might be taking advantage of. If there are waivers in place, we may not decide to either do a virtual survey or an on-site survey because there's waivers to those conditions of participation, for an example, and that's part of what we do, is evaluate those conditions of participation. If there's an issue with a condition of participation and a waivers related to maintenance contract because they can't get a vendor to come out, we may still go to an organization, or we may still conduct a survey, but that certainly would be a finding that would require follow-up and then would need to be corrected. We want to make sure that there are no alternate care sites that are still being used. We want to make sure that elective procedures are resumed. So we're trying to get an idea that the organization can support a survey or review, and that they are not actively in an emergency response status. We also want to make sure that if we are coming on site, that there's adequate protective equipment, and we want to get a sense for source control within the organization. Next slide, please, Mary. And then, should we have an on-site survey? There were a few points that we just wanted to make as part of this presentation of what you can expect that would be different than a typical on-site survey and review. So our surveyors will wear whatever PPE you would want them to wear. If it's masks, if it's goggles, if it's gowns, if there are other pieces of equipment that you would want our surveyors and reviewers to wear, then we would wear those. We would also expect that there would be sufficient supplies to provide our surveyors. We're going to work hard at social distancing, which would include limiting the number of individuals that come along with us during survey and review activity. We also will be working to use technology that would allow participants, as many participants that you would feel necessary to be involved in a particular activity, but using technology in such a way that we could still maintain that social distancing. We'll drive to distant locations as opposed to rideshare. And then I wanted to share too that during the public health emergency, beginning March 1st until you are ready for survey, or the end of the public health emergency, that the documentation within the record won't be the focus of our activity. We'll still review it as our evaluation of key processes occurs, but we realize that during public health emergency, there are changes in documentation. We'll look to see what your policies are around crisis documentation or other allowances that you would make during the public health emergency, and would honor those as best that we could. Mary, I believe our next slide is where Ashley will begin, and Ashley will give the details then about our virtual survey and review process now that we have the background hopefully established for you, so you can better understand where we are and what has factored into our decisions about expanding virtual surveys and review. Ashley?
Thanks, Lisa. As Lisa mentioned, I'm going to shift the focus to more specifically the detail of the Joint Commission virtual survey process. We are currently conducting virtual surveys across all of our accreditation and certification programs, which you can see listed here on the slide. Every program does have a virtual survey option, although not all organizations are eligible. For example, as Lisa mentioned, we can conduct all behavioral health care events virtually, although some states have virtual restrictions which do not recognize the virtual event. Additionally, for CMS deemed programs, we apply eligibility criteria set forth by CMS for virtual survey eligibility, to determine if an organization is eligible to participate in a virtual survey event. One of the key differences between a virtual and on-site survey or certification review is that for deemed programs, many do require a return on-site visit to the virtual event, which you can see here for those programs as well. Although you will see here that we primarily have been conducting virtual surveys for initial organizations amongst the deemed programs, which do include hospital, critical access hospital, ambulatory surgery centers, and home health and hospice organizations. We did recently receive notification from CMS of approval to conduct resurvey events virtually, although we are continuing to work with CMS to understand the approved criteria in order to begin conducting those events. So with that, we have continued to focus on the initial organizations for the deemed programs until we can begin those resurveys as well, which we know is anticipated by some of the organizations. You'll also notice for our disease-specific care certifications that only for our comprehensive programs are we returning on site. Our comprehensive programs are primarily our stroke and cardiac programs, as well as a few others. Next slide, please, Mary. Okay. So now that we've outlined what types of organizations and programs we're conducting virtual surveys for, I wanted to review with you what the virtual survey process itself looks like. For each organization identified to be eligible for a virtual survey or review, we are conducting what we call a dry run call with the organization, which is really aimed to test the technology needed to conduct the virtual event with them. Having a dry run call is one difference between the virtual and on-site event and the need to have technology in order to conduct the events virtually. We have found that the test of the technology prior to the event has really been critical to the overall success of the virtual survey event. Although we do expect to be using more technology in the future as well, technology has been a crucial component, and you can see that here on the slide how we have used technology during the virtual surveys and reviews. This includes using technology to allow organizations to upload documents prior to the survey event taking place. We provide organizations with a list of required documents that they must upload, and those documents then are shared with the surveyors and reviewers to review prior to the event taking place in preparation. We also use technology to share screens to review patient records, HR and credentialing files during the event, as well as the use of webcams in order to conduct any tours at the organization and conduct those patient and staff interviews. In order to accommodate for the new use of technology within the survey process, we have an updated contract to permit virtual survey activity, which is signed by the organization prior to the event occurring, so they now know what they can expect during the virtual event. These are just a few ways we've leveraged the use of technology to help the success of the virtual survey process, and we continue to identify additional ways, as Lisa mentioned, as we continue to expand the virtual survey process as well. After organizations complete the dry run and the technology has been confirmed with the organization that it will work for the virtual survey, that's when we start the actual scheduling process for the virtual event in the organization. Next slide, please. Okay. Although we've shifted a lot of our survey activity to the virtual survey format, we have continued to maintain that unannounced survey process where required. So most of our surveys and reviews are unannounced and remain that way for the virtual survey as well. Organizations do receive notification the morning of the event. They receive that notification through their normal notification avenues, which is their organization's secure extranet. So they log in each morning to check if the event will be occurring. The notification they receive for the event does include a Zoom meeting invite. So we are using the Zoom platform in order to conduct the virtual events. And that meeting invite is embedded into the agenda for the survey event that gets posted. So the organization, they can forward the Zoom invite to those applicable that they want to participate in the virtual survey event, but that Zoom invite is what actually connects them to the surveyors and begins the survey event. Next slide, please. Okay. Similar to the on-site survey process, the organization receives a timed agenda of the activities which will occur during the virtual survey event. The specific length of each virtual survey is determined by the program as well as the type of organization being surveyed. We have ensured, though, that we conduct a sufficient activities virtually in order to recommend an accreditation decision at the outcome of the virtual event. So they do walk away with a decision as well as an award letter after all necessary pieces are addressed. Currently, for example, for the hospital program, for initial organizations, we do conduct a 4 surveyor day virtual survey. So just as an example of what we typically have been doing for one of the programs. You can see here on the slide, there's a sample portion of an agenda used for a virtual survey. Although I know it is small here, but you can see the various survey activities. You can see that we notate for the organization as well when lunch and breaks occur and when the organization can expect to turn their camera off during the survey event. That's really helped the organization to let them know what they can expect during the survey day and who they should have available for various survey activities as well. At the conclusion of the virtual survey event, the organization, as I mentioned, does receive a report and any applicable post-survey follow-up. That follow-up does follow what our normal process would be if they were having an on-site event as well. After any applicable post-survey follow-up is completed, the organization does receive an award letter as well as an accreditation decision as an outcome of their virtual survey event. Next slide. For those surveys which require an on-site event following the virtual survey, the post-virtual on-site event really is intended to build upon the work conducted during the virtual event. Some of the differences in the post-virtual on-site event will also emphasize the conditions of participation or COP compliance. In case, as Lisa mentioned, any of them might have been waived during the time of the virtual survey, so we would look at those when we return for the on-site visit. We also will take another look at any of the findings that came out of the virtual survey event while we're on site. So we'll look at anything that might have come out of that virtual event. We'll also take a look at certain high-risk areas that we want to look at again while we're on site. These include things such as surgical procedure areas, emergency, behavioral, and intensive care areas, as well as pediatrics and imaging, just to name a few. And then we also want to make sure we have an opportunity while we're on site to interview patient and staff. We try to do that during the virtual survey process, but we also want to leverage that opportunity while we're on site. At the conclusion of the on-site event, the organization will receive a report as they would any other event, and then along with any necessary post-survey follow-up as an outcome of the event. So we tried to align the post-survey process to what organizations are used to and have come to expect as far as the on-site event as well. Next slide, please. So that's really a high-level overview of our virtual survey process. We thought we would share some of the feedback and lessons learned as well. As Lisa mentioned, we've continued to learn and evolve over the course of time that we've been doing the virtual surveys. Overall, we are really confident that in our virtual survey process, the organization feedback has indicated that we have been able to provide as well as maintain a meaningful assessment using the virtual survey model. The document review prior to the virtual event has received a lot of positive feedback, both from the organizations, also as well from our surveyors and reviewers, that it really has better prepared them and made them feel more comfortable going into the virtual survey event. Feedback from the surveyors and organizations as well has indicated, and this is what we hoped for, that it really does feel like a normal survey once they can get over the fact that the surveyor is in the computer and not actually on site with them. So we were really happy to learn that feedback because that is what we aim for. We want to try to maintain what they normally would experience in the on-site survey as well. We've also, and I think Lisa mentioned this, we've been working with our Department of Research to analyze the virtual survey for those programs that we've conducted enough that we have a sufficient number to compare, and that we've found that there really is no statistically significant difference among the scoring patterns when we're doing virtual events as compared to traditional on-site events in all of our programs, with one exception, which was our hospice surveys, which we did find, our Department of Research found that the number of findings virtually are higher in traditional surveys for hospice compared to the virtual survey. Although after looking further into it, the difference in the hospice numbers we do believe was more of a function of limitation in the ability to enter facilities during the pandemic, and that some of our work was actually observing those hospice organizations using technology to conduct their own site visits. For example, some hospice patients were in long-term care or inpatient units where access was limited, both to the organization as well. So we do feel that there is some rationale in that difference in the hospice program findings. We also have continued to really just improve the process over the short period of time we've been conducting. We do frequent touch points to recognize any areas we can improve upon. We had found some limits early on in regards to what we could observe in the environment, and we've tried to learn how to do a better job of observing those areas over time. So for example, getting used to using the webcam. Surveyors will, have learned to kind of pause and ask staff to turn the camera left or right, or to look at specific things. So kind of just getting used to the virtual environment. Or they'll ask, as a staff member is walking through the hallways, for them to keep the camera on so it allows them to stop and ask questions. For example, can I see that fire extinguisher? Or they might see a passing staff member that the surveyor might want to ask a question. So we really have worked on the lessons learned and taken those to kind of optimize the experience, both for the organization as well as the surveyors. We do continue to collect and analyze from the lessons learned thus far, and we continue to identify opportunities to be more efficient with the technology, both in the virtual survey currently, but as well as in the future. So we are using that detail in order to inform a more efficient survey process in the future for both virtual surveys, and recognizing that some of what we're doing virtually may be able to be leveraged for on-site surveys as well. So we do have an initiative in place to leverage the detail learned to look at what a survey of the future per se could be, including things like leveraging that document review that we're doing ahead of time as part of the virtual survey, reimagining our system tracers, and really how can we use video conferencing to include remote sites where typically on an on-site we might have to travel a significant distance to visit those sites, and incorporate staff, as well as using video conferencing just to observe additional staff survey activities even when we are on site. So overall, that's a little bit about the lessons learned, a high-level overview of what the Joint Commission has done to meet the needs of the current environment, and how we have adjusted and implemented the virtual survey process. So with that, any questions?
Ladies, there are no questions as of this moment.
Well, I know we went through that pretty quick. Maybe folks would just take a minute to think about it, and if there's other questions, then Ashley and I, and Mary is with us as well. We're happy to answer any questions that y'all might have.
And I do know, Mary, on the next slide is Mary's contact information. So if there are any additional questions as well, and you want to learn more just overall about the accreditation and certification programs, Mary, as Lisa mentioned, is on the line, and her contact information is here as well.
Well, ladies, there are still no questions. I wanted to also let everyone on the webinar know that this has been recorded and will be available for review. Oh, we do have one question. Now their questions are coming in. First question is do you have any trouble accessing medical records remotely?
Well, I can start with an answer for that. This is Lisa. Part of the dry run is to evaluate an organization's ability to share screen. And so that's, when there's electronic medical records, that's when it seems to work the best. For those organizations that may have medical records on paper, what does not work very well is to hold the paper up to the camera on the computer or whatever device we might be using. So we've had to be very creative in allowing organizations time to scan documents so that we can make use of the share screen function as opposed to try to hold paper up to the camera. So our surveyors have they've been very creative in how they've if we're just learning the day of survey that there are issues there with some components of the record being on paper, we will designate someone from the organization to scan these particular pieces so that we can come back and look at that information once it's scanned into their system so that we can do share screen instead of holding paper up. Now, if it's a log and we just need to look at a couple of items, holding a piece of paper up to the screen is workable. But when there are policies, procedures, medical records, other documents where we really need to provide some level of detailed review in a number of pages, we will allow folks to do some scanning of that information. So electronic medical record policy and procedures, we haven't run any trouble there. It works fine. It's just those paper records where we have to give the organization time to do some uploading so that we can review. But our surveyors have gotten good at adjusting the schedule to allow for that. And after all, well, by January, we'll have conducted over 1,200 virtual events. So that's a lot of time for us to figure out what works and what didn't work and make improvements to our process. But Ashley, do you want to add anything to that?
No, the only thing I'd add, Lisa, is one thing I probably should have mentioned is as far as that document upload prior to the survey event, we do ask that no PHI information is included in that. So to Lisa's point, a lot of the medical records are going to be done via that screen share or webcam.
Okay, second question. How do you ensure staff can be anonymous and honest on interview if the facility is present and knows who you are interviewing?
Oh, that's a good question. And this is Lisa again. One of the things that we do is we will ask the organization, if we could, or when we select a patient to interview, for example, would that patient be able to hold the iPad or whatever the technology might be that we're using so that we could interview that patient privately. The same thing with staff. It has been a challenge whether we're virtually or when we're on site. If we go in a patient's room, you know what patient we're speaking with. If we have several staff members in a room, those staff members, or the organization knows those staff members that are participating. There's always the option in our survey and review process for staff members or the public to reach out to us at the Joint Commission to share information anonymously so that we can evaluate those type of concerns without having the individual making the concern knowable in that case. So there has been some challenges with virtual survey in the use of technology, and we've had to figure out alternative processes to the organizations holding the equipment for us to have the opportunity for those private discussions with staff as well as patients. But we have figured that out, and what we plan to do when we go back on site is to conduct those private type interviews while we're there in site as well as virtually, not acknowledging that there could be some limitations depending on the technology for those virtual events. Ashley, do you want to add anything, or Mary, do you want to add anything to that response?
I think you covered it, Lisa.
Yeah, I agree. I think you've covered it.
Okay, next question is, would you share with us again your percent positive that you currently use to determine when to do regular on-site and when to do virtual?
Yes, I'm happy to do that. Right now, we're looking at a prevalence of 3 to 3.5 per 1,000 population. And that has been modified at least 3 times since June, at least 3 times since June. And as there are more data available and more research that would support a lower risk with a higher prevalence, then we make those adjustments. So we have our own Department of Research that keeps up with that level of detail and recommends modifications accordingly. So right now, we're looking at 3 to 3.5. That could change in the future in either direction. As more information becomes available, we use that data to make changes. But right now, 3 to 3.5 per 1,000 population is what we're using to determine a lower risk county. So if you are a 4 over, your prevalence is 4 of 1,000, then we would look to see if your organization would be eligible for a virtual event, depending on what type of event that you have pending, whether a virtual option would be available for that particular event or not. Ashley
Okay,
or Mary, do you have a better way to explain that than me?
No, I think you got that one too.
Okay.
Yeah, I think you got that one. I do want to share that we have shared the gating criteria with some of our states. We have not shared it widely because for a while it was an internal document only type of thing. So while we don't want to blast it out to the public online, we are willing to share that with our state stakeholders. So if you do want that information, please reach out to me and I'll make sure you have it.
Okay, next question. How is the survey unannounced if you have to test the equipment? And what specific equipment do you use?
I can take that one, Lisa. So we do an initial outreach call, I think Lisa mentioned, just to confirm with the organization based on the criteria for the virtual survey, whether they're eligible. And then we do connect with that organization to ensure we do use Zoom. So we ensure that during that dry run call, we test that the Zoom is working, that they do have the ability to use the video. If they have a webcam or anything that they're using, we test that technology as well. We try to really test anything that they might be using, whether it be an iPad or a different type of webcam device. We try to test that during the dry run. And now the dry run takes place in advance of the survey. So as far as the unannounced element of the survey, we do check with the organization during the dry run, but then after the dry run is concluded, when we start to schedule the organization's survey with our scheduling department, at that point the organization is no longer informed essentially as to when they're going to be scheduled. And similar to our normal on-site process, they find out that morning of. So they do get the call in advance just to confirm the technology. That can very much vary as far as the time between the dry run call taking place and when the actual survey takes place as well. It could be, days, it could be weeks. So we do as much as we can try to maintain that unannounced criteria.
Okay, next question. At the end of the public health pandemic, will you keep the virtual survey model permanently?
I can answer that one as well. Oh, go ahead, Lisa.
Go ahead. Oh, sorry, Ashley. No, you go ahead. I'll jump in if there's more to add.
No, I was going to say we do anticipate keeping the virtual survey in elements that we can. A lot of our ability to conduct the virtuals, as we mentioned, was contingent on approvals from CMS in order to conduct virtual surveys for deemed organizations and some of the states. So a lot of the states as well as CMS have put parameters around the ability to conduct the virtual, most of which are contingent on the public health emergency being in place. So for those organizations or event types that we do hope that we can continue to do the virtual survey. We have received, as we mentioned, quite a bit of positive feedback, but unfortunately for some survey events and organizations based on regulatory bodies, we may not be able to after the public health emergency has expired. Lisa, anything to add there?
Well, I'd love to, because we're using these lessons learned, and actually it talks about some of those lessons learned in moving forward. What seemed to work well? What can we do, in our surveys of the future? So, for example, we had gotten a lot of positive feedback, both from our surveyors and our organizations, about uploading certain documents, policies, and procedures, for example, ahead of the event. Our surveyors review that information before the survey starts, and some of the feedback we've received is that the surveyor then can focus on care processes, not reviewing documents, policies, and procedures. That's done ahead of time. And so it has made the actual virtual event, in the words of our surveyors as well as organizations, more focused on care. And both parties have appreciated that emphasis and the focus on how care is delivered. If you have to look at policies, procedures, for example, some of those documents to know what to expect, but having some of that document review done ahead of time has been received positively by our organizations as well as surveyors. So that may be something that we'll continue to look at to see if we can incorporate that into our survey and review process going forward, just as an example. So we are looking at our lessons learned, seeing what technology might be able to do for us in the future. We've had some feedback that by using some of our virtual platforms, that more people can participate in survey and review activity than what they have been able to do in the past. I'm thinking of one particular organization that the administrator, it was a nursing care center, the administrator was able to participate because he could log on to the Zoom process and see what was happening and could participate that way in his office, as opposed to if he had to follow, walk with the surveyor, may not have had that time. He could be available, and some multitasking, I guess, would be one way to include it as well. But we have had feedback that more people could participate by using technology to be included in some of the discussions that we were having. So I think we're going to be able to use some of the lessons learned going forward outside of the public health emergency, whether we continue full surveys, virtuals, and reviews virtual. There are restrictions to some of our programs, but in our non-deemed programs, we've had some good work and evaluations, like, for example, in our healthcare staffing certifications, in telehealth certifications, where technology is used regularly anyway. We may be able to include more of a virtual, more of our virtual work in certain programs than others.
Okay, the next is actually a comment. Sometimes I've noticed IT does not allow off-site access.
We haven't run into that that I am aware of, and that is part of those outreach calls and eligibility calls. We want to make sure that any issues with security are addressed. We work with some of our government programs, and there's been some issues there that we've had to work around with restrictions in what is allowable and what platforms that can be used. But I'm not aware of any other issues. Ashley, you may know more if there's other issues than what I've mentioned here. Are you aware of any that we've had that might add to that comment?
Yeah, not that I'm aware of, Lisa, like you mentioned, we do have some particular organizations, particularly those government organizations that we've, during the dry run, had to make sure that, they could use the technology, that access was granted if needed, but I don't believe we've had any issues in regards to various locations not being able to use the technology.
Okay, next question. Are the surveys recorded?
No. That was an easy one, right? Ashley, you don't know of any other answer to that, do you, or Mary?
No, yeah, I would agree.
In fact, we ask that they not be recorded. That's one of the stipulations.
Okay. How are patients and family feeling about virtual interviews? How do you ensure privacy?
I can start with that one. I've observed a number of our virtual surveys, and with our patients have been fascinated about the technology. And it's been so interesting to me because, we weren't sure, how patients would respond to, hey, will you talk to this person in an iPad? But they've been fascinated by it, intrigued by it, and wanting to participate. So that's been interesting. I wasn't quite sure what to expect. I think as our surveyors and reviewers have gotten better about explaining and making that contact, even though it's through a screen, we've gotten better at that as well. As far as the privacy, we are very careful, and we work with the organizations, that to be sure to position us appropriately, where if we are observing care, that that we are not observing private areas, or the things that we do ordinarily, while we are part of a survey and a review. We do the same virtually, as far as now making sure that the patient is expecting us to come in, and that they know what to expect, that we will, be with technology, and that, we want the patient's privacy to be maintained, as far as, depending on, dressing changes, as an example that comes to mind, that we would want to make sure that the patients are appropriately covered, and just like we would do while we are on site. What gets a little tricky sometimes is that we want to make sure that we have processes in place that the patient can speak to us privately when the organization would come back into the room. Some of those type of operational details, we've gotten better at the more we have conducted our virtual surveys and events. Do you want to add anything, Ashley?
No, I think you covered it.
Okay, next question. Let's see. What is the process for organizations who delay the survey process to get approval from their corporate offices to release information to you? Or has this not been an issue?
Well, I would say it's not been an issue. And I probably should leave it at that. Um, but there may be some delays for whatever reason. But we operate in good faith, and feel the same about our organizations. I'm not thinking of any particular delays that we might have. I know that sometimes it takes organizations a little longer to move from the eligibility or the outreach call saying, yes, we'd like to have a virtual event, until we can actually schedule the dry run or test of technology, because we may do the outreach to an accreditation contact person, who then needs to speak to the quality director, who then needs to speak to the C-suite, and then we need to get feedback from IT. And so that's a lot of folks that need to be involved in discussions before we can move forward. So sometimes that might be 2 weeks between when we have the initial outreach call to when we can schedule the dry run test of technology. Would you agree, Ashley?
Yeah, I would agree. So to that point, as Lisa mentioned, there's a lot of coordination on the organization side where most times their corporate office is well aware that they're going to be participating. So we have not heard of any issues per se that have been caused by a delay of organizations trying to get things from their corporate.
Okay, final question. Did CMS require any changes to the survey process when you moved to virtual surveys?
Well, the one that comes to mind right away is that we do a virtual survey and we have to go back on site to validate or to conduct another similar type survey. So that's definitely a change or a difference where we had one event in the past, we have 2 events now. So that's the first thing that come to my mind. Anyway, this is Lisa speaking. Ashley, what about you?
Yeah, I think they did put in place criteria, and we did outline what we had hoped to do during the events, and all of that had to be reviewed by them, which they then gave feedback. So, we tried to stay in line with what our normal process was and what organizations were used to from a survey activity perspective. But to Lisa's point, we did have to make some modifications as well.
So that was the final question. You guys actually answered them all. As I stated, the webinar is actually recorded and the slide deck and recording will be available on the AFSA website by Friday. Ladies, with no further questions, AFSA would like to thank you, tremendously for this webinar and the time the Joint Commission has put into providing this for our state agencies. Again, if there are any questions, you can follow up with Mary Wee. Her contact information is on the screen. Again, we thank you so much.
Thank
It's
you.
our pleasure. Thank you all.
Thanks, everyone. Thanks for your time.